Can AI be used to help in the diagnosis of bipolar disorder, and will that be accurate? So this is an excellent question. I'll first start by just talking about the challenge of diagnosis of bipolar disorder. When we're in med school, we learn the symptoms of let's say mania. And then when we're in the emergency department, we realize that textbooks are great, but the reality can look very different. And even as a psychiatrist who did a fellowship in mood disorders, and this is a big part of my practice, is really specifically with bipolar disorder. When I work in the ER, do my call shifts overnight, it can be really hard to figure out somebody's presentation, right? They might have some of those classical symptoms of mania, but they might also have a lot of psychosis. And then when you ask them about the history and their family member, you get kind of a difficult history. And it can be really hard to figure out, is this actually bipolar disorder or a lot of other mimics? And similarly, I think a big challenge is often in comorbidities or other medical conditions that are also present. One comes to mind that's often really difficult to disentangle is ADHD, which we know is actually quite frequent in people with bipolar disorder, but can also be hard, right? Because in ADHD, you could be very focused on a task for many hours, maybe forget to go to sleep, and other symptoms that can look at mania. But yet it is a very separate disorder and needs separate medications to really help someone live with both of these conditions. So I believe one of the excitements is that we could really be using AI to help figure out diagnoses and clarify things better, right? Another application is around the gigantic delay it takes to get people a diagnosis of bipolar disorder. Especially if their episodes tend to mostly be depression, it could go years, if not even decades, until these are finally diagnosed. So there are lots of efforts underway to really help use AI to clarify diagnoses and understand what someone is dealing with sooner and better. There are different modalities and data sources where these are being investigated. So this can include neuroimaging, taking scans of the brain and trying to use AI to predict what sort of mental health condition somebody has. These are showing promise, and there is some really neat work showing that these different brains can look different. A brain that has bipolar disorder and a brain that has unipolar depression does have some differences that we're already being able to disentangle. There's also things like genetics and biomarkers that floating around the blood, trying to figure out how we can use those to figure out different diagnoses. And again, we're starting to see some promise. And then there's more clinical aspects. And these are the ones that myself I've been using in terms of things like actigraphy or somebody's activity that we could see if they're wearing a smartwatch. Or even things within their medical history. Let's say seeing their presentation in their notes when they see different doctors or go to the emergency department. We can use AI to actually read some of those notes and start to figure out, what condition does this person have? Or we can even look at their symptoms and looking at clusters or constellations of symptoms, understanding those that might represent somebody with having a bipolar disorder, maybe also with ADHD, is it bipolar 1, is it bipolar 2, so on and so forth. So we are actively investigating these to figure out whether we could use these tools. Now, one of the interesting questions, though, is the accuracy, right? One of the reasons I went into psychiatry was because it is so amazingly complex. The human brain, mental illness in general, is just something that involves so many aspects of ourselves, of our environment, of our socialization, of our genetics, of our biology, of our diet, of our activity, of our jobs, of our family, that all these things are going to be interacting with each other, right? I also do some work in cancer psychiatry, where we're looking at mental illness in people who have cancer. And, I don't want to say that cancer is simple, but whether somebody has a tumor or not is relatively straightforward. You can usually scan it, you can look at it, you can then do a biopsy, look at the cells. Sometimes there's going to be some complexity in there. But it doesn't quite involve so many multiple interacting aspects that mental illness does. And so because of the complexity of how all those things interact, it's going to make the prediction also more difficult. And that's why I believe that we're probably going to also need to be looking at multimodal predictions. Predictions that actually take different types of data in to really understand things. So maybe you need to do a brain scan, but maybe you also need to understand what's going on in the blood, but also understand the person's symptoms and kind of how they're functioning in the world, things at work, and put those all together to see what's actually happening. And even if we do that, there's also this question of inaccuracy, right? Generally speaking, with AI, it's easy to get the first 70%, 80%, maybe even 90% of accuracy for a prediction. The reason being that 70, 80, 90% of the time, things are going to look pretty similar. right? So for example, somebody's manic episode might have the classic symptoms. They might be talking fast, lots of energy, they might be very grandiose and really happy. But 10% of the time, their manic episode might be really different. It might be a mixed state. They might be having both kind of depression and mania happening at the same time. Or they may be prominently having psychosis. And so it's hard for the AI to pick up on these patterns when you want to get things that are a bit more rare, right? And so this brings up, I believe, lots of interesting ethical questions. Do we want to use a tool that has 80% accuracy, right? And often the quick response I get is, well, no, I want the tool to be using better. But I would say that instead we shouldn't really be thinking about it in absolute terms, but be thinking about it relative to the current state. So again, I'll have to use a terminology from the cancer world, but we built a system that predicts whether someone with cancer, just at their diagnosis, is going to need to see a psychiatrist. With the idea of hopefully we could see those folks ahead of time before their mental illness gets really bad. We can maybe see them earlier, get them other resources first, right? And the system we built was actually, it depends on how you kind of look at it, but probably around the 80% mark in terms of accuracy. So pretty good, but definitely not perfect, okay? Yet, we also have studies that show that oncologist, after their first appointment, can really predict mental health needs correct about 33% of the time, right? And I'm not throwing my oncologist colleagues under the bus. They're experts in killing cancer cells, not in mental health. And they also have a ton of other things to be going on in that first appointment. But would you rather have something that's 33% accurate or something that's 80% accurate? And I believe that having those relative amounts of performance is really going to help us understand that, oh, maybe this AI system isn't perfect, but could it help the current state quite a bit, right? And that then brings us into an interesting question of human in the loop. You've probably came across this term. It really means the idea of using an AI alongside a human. Or as I like to say, both the artificial and human intelligences working together, right? Now, in the bipolar world, we are really at the start of really figuring out a lot of these questions. I recently actually just did a study looking at an AI tool that can help clinicians correctly or appropriately use the correct medications for somebody's current situation in their bipolar disorder. And it was interesting to just see the different variety of responses that these expert psychiatrists would think in terms of what medication should be used in a certain scenario, right? So we're going to have to think hard about how to do these evaluation studies, especially in a field where it's science-based, but there's also an art to a lot of these aspects. So coming back, the human in the loop aspect is something that we're going to need to be looking at. And again, if I leave the cancer world, because in some ways, so a lot of the AI stuff has started to be looked at more extensively there. One of the interesting results that if you use AI to look at, say, like a mammography, to see whether there's a tumor there and it needs further investigation, currently a lot of the studies are saying that the radiologist, the human radiologist, and the AI system work about as well as each other, right? But the best is actually if you have them both look at the mammography image, because the AI and the human make different mistakes. So having them work together actually complements each other. And I really believe that a lot of these systems that we're going to be working on next in terms of the integration of AI into bipolar disorder are going to really be benefiting by combining both humans and AIs working together. Because again, our brains work very differently. AI is, you could say it's designed to actually mimic the human brain in a lot of ways in terms of how we design neural networks. They do have some inspiration from the neurons in the brain in terms of the math and the ability for the components to kind of interact together as ones or zeros, kind of similar to a neuron either firing or not firing, depolarizing or polarizing. But as of yet, they still have very different strengths and weaknesses in terms of their abilities to use different information that they've learned, how much information, so on and so forth, right? And so I do believe, especially in terms of how clinicians and AI will be interacting, it's going to be that kind of symbiotic partnership for many years to come. Folks often ask when I talk about AI, well, is AI, if you're a psychiatrist, is AI going to take our jobs? My first answer is usually, well, I'm an AI developer in psychiatry, so it's not going to take my job, yours. But no, that's mostly a joke, because the analogy I like to use is airplanes, right? We have had AI or AI-ish systems in terms of autopilot literally for decades, right? Going back, 20, 30 years easily. And AI is actually really good at flying planes for the most part. I've talked to some pilot friends and they say, yeah, you probably even want the autopilot to be doing takeoff and stuff like that too, because it's just so reliable by this point. But when I go on an airplane in a few months, there better still be a pilot on board, right? And again, the AI is, as we improve the systems, the accuracies could get closer and closer to 100%. But there's still going to be that 1 or 2%, those really rare occurrences that it's really when you're going to need the human intelligence. Because maybe you've seen that before, or maybe you'll be able to piece together so much of your previous knowledge and previous experiences that you could kind of adapt and figure out that situation. Whereas, while AI systems are getting better at this, AI tends to work essentially on pattern recognition. So if they haven't seen a certain situation before, it can be more difficult for them to adapt their previous knowledge to this new situation. They're getting better at that, but I still think for the next quite a long while, we're really going to need humans to help with the rare occurrences especially.